Okay, so let's go ahead and get started. It's a pleasure to introduce Dr. Shah, and she's going to tell us about echocardiography. I want to also mention Dr. Huie Lin. He is actually the co-director of this. GOPI and Huie work together. When you talk about strategic planning, what we managed to screw up was the fact that the cardiology fellowship interviews are today. So our cardiologist will reappear sometime this afternoon. So GOPI, thank you for coming.
Good morning, and I'm going to start this talk with the basic in imaging, which is the echocardiography. I think even in spite of great evolution in the field of multimodality imaging, echo remains the bedrock, more so now in the intravascular and interventional cardiology field. So one of the basic advantages of echo that remains very solid is that it's very portable, it's hence can be intra-procedural, amazing spatial resolution of the structural details. It is functional, its hemodynamic data is real time, and really there are no contraindications. So if a person can undergo an interventional procedure, they can definitely undergo the echo. A brief overview here. Esophagus sits right behind the heart. You put the probe in the esophagus, and you're able to get excellent resolution, high resolution images of the structures that we are most interested in, which is being the valve, the interatrial septal, the atrial appendage. And again, this image clarifies that further. As you can see, the top portion is the interior portion where lies the pulmonic valve, and your probe is in the esophagus posteriorly, and you have excellent view of the aortic valve, the mitral valve, and the tricuspid valve. You can see the scallops, you can see the cusps very well, and that makes echo kind of irrepressible in intravascular intracardiac procedures, especially given the hemodynamic data that we are able to get. Again, images that show how well we can look at the heart, particularly the left atrial appendage. And I wish there was a pointer that I could show you with, maybe here. So you can see the left atrial appendage here. You can see it in a cross-sectional view here. And really this, as you see more real-time images, you'll appreciate the high spatial resolution. So where are we currently using the TEE and transthoracic echoes? Currently in the interventional cardiology fields, the left atrial appendage occluder, it remains a modality of choice for assessing the left atrial appendage prior to the procedure, during the procedure, and even post-procedure. Mitral valve crib, again, TAVR, ASD closure, new kid on the block, which is the transapical mitral valve replacement. Pulmonic valve remains challenging. As you notice, it was a much interior structure, and cardiac MRI has a better role in defining particularly the RV size, RV dysfunction that are pivotal when addressing a pulmonic valve pathology. So without much ado, this is the left atrial appendage being imaged. This is a still image where Dr. Valderrama actually measures the appendage size. And here you can see transeptal approach of the catheter. You can see it here again as the catheter is approaching the left atrial appendage. So what are we looking for when we do the TEE? We are looking for, first of all, there has to be no thrombus. If you have a thrombus, it's an absolute contraindication to the procedure. Then you're looking at the morphology of the left atrial appendage. All appendages are not created equal, and therefore there is significant difference in the appendage size and the morphology. Classically, 4 have been described: the chicken wing, the windsock, the cauliflower, and the cactus. Basically means whether you have one lobe, multiple lobe, how is it angulated. And this is very important because anytime you're putting an occluder device in, sizing is very important because the success of the procedure depends upon the size, how well you can occlude the appendage, and whether you have a para-occluder leak. Again, this is in fully deployed, sorry, I skipped. So as you can see here, you have the occluder in place. Again, this is a still image showing how occluder sits right below the, this is your warfarin ridge, your pulmonary vein here. And if I could play this image, right. And you can see the catheter here as it is deploying the occluder device. And this is a still image of the 3D and how occluder looks when it's been sealed. So why is it important to assess for the sealing and the leak? If you have more than 5 millimeter space on the sides of the occluder where you can see blood flow, then these patients still need to be on anticoagulations because they can form thrombus, as the next imaging I'll try and show you after this. So you can see here again, you assess for the residual ASD leak because you are creating an atrial septal defect. You're also looking, as I mentioned, for the integrity of the occluder, and you're looking for flow in these regions surrounding the occluder device. This was a very interesting case. This patient had a TE follow-up post-occluder, and I want you to focus. There are a lot of images. This is what it first looks like. We go on, we try and see for the flow. You don't see much, and it shows how complex imaging actually is. Until you go through all the planes, you could potentially miss something. And here what you're seeing, this is an thrombus that sits right on top of the occluder device. So this patient, despite having an occluder device, has developed a thrombus. And this obviously has clinical implications. Moving along, the mitral valve clip. So echo is pivotal in deciding which candidate is good for the mitral valve clip. Obviously, you have to have significant functional MR, and MR due to a failed leaflet is also a good candidate. However, there are certain parameters that have been very well identified in terms of what do we look for the morphology for mitral valve clip. And as you can see, anterior leaf, posterior leaflet, your posterior leaflet, even though area-wise is the same as the anterior leaflet, is a much tethered leaflet. And the subvalvular apparatus also plays an important role. Here, this table lists the things that we look for. One most important thing is the length of coaptation and the depth of coaptation, or the zone of coaptation, which is the rough area below the smooth leaflet line of coaptation, which is somewhere around here. Leaflet thickness matters, and if you have marked restriction of posterior leaflet, you're obviously not going to be able to have the coaptation, and lack of primary or secondary caudals, and of course multiple jets precluded. Again, as I said, these are the few things that would make you not a good candidate for mitral valve clip. So again, echo is you assess, and here you can see you have the anterior leaflet and the scallop collapsing. Then you have beautiful, what has made echo really a great tool is the lovely real-time 3D images that we are able to acquire. And you can see here the anterior cusp that is kind of prolapsing in. There is a flail component to it that you can see. You see a real-time data. This is right in the cath lab while you're about to proceed with the procedure. You see the MR jets here. And here you can see the catheter being advanced. So this is how it actually looks in the cath lab. You are having the catheter being advanced. You're seeing the position of your clip. You're now going to go ahead and grasp the leaflet and place your clips. What next do you do? You're going to assess for the residual MR. Do you see any significant MR? What is the positioning of the clip? And again, beautifully shown here in 3D, lovely clip. Now we have two little orifices here for your blood to flow through. I'm going to show you a nice case with just, okay, I'll go through this first. So again, pre-mitral valve and the post, and for some reason this image doesn't want to play. Can they play this? Anyway, you can see two jets, eccentric jets. Here now you're seeing just mild residual post clip. So again, what is the importance? Transseptal puncture, introduction of the guide catheter, advance of the delivery system, positioning of the clip, grasping of the leaflet, and evaluation of residual MR and iatrogenic mitral stenosis. This was a fascinating case, 81-year-old person who had both a severe MR as well as aortic stenosis. And the patient, as you can see, has a flail leaflet here, anterior leaflet, which is flail. You can see a very eccentric jet of the MR, which is significant. This is a sclerosed valve, and you can see from the gradient that it's almost 4 meters. And this patient underwent first TAVR, and again, you're seeing the residual gradient post-TAVR, and I'll come back to TAVR later. But what I wanted to show how important dynamic imaging is in determining during the procedure how many clips need to be placed. So this patient was going to have again, a transeptal approach. Here he's going to have the clip placed. And they assess the MR post-placement of the first clip. And as you can see, there is significant MR still there. So they again reassess the valve. You can see two beautiful orifices, lovely clip in the middle. And then decision was made that we need to put another clip too. And here you see Dr. Barker was going to go and put another clip. You see a little bit of MR there. This is after the second clip has been placed. They look for the gradient. Please flip the image if you're used to seeing it. And you see that the mean gradient is only 2 millimeters. So now this patient has undergone successful deployment of a second clip, again emphasizing the importance of intra-procedural imaging. And of course, this is a post follow-up and things we look for in ASD, residual ASD. This is transthoracic post follow-up showing very little MR. So great results for a patient who underwent 2 valve procedures. And that was the aortic gradient. Coming to TAVR. So TAVR was one of the first valves to be placed percutaneously. And these are the 2 valves, the core valve and the sapien valve. And you can see that they look significantly different. The role of transthoracic echo in determining the size of the prosthetic valve is not as robust as the CT. And the reason is you want to oversize the valve, you want to deploy a valve that will prevent paravalvular leaks. Therefore, CT has proven to be more robust. Again, these are more complex patients. They undergo CT chest, abdomen, pelvis because the vascular access remains challenging. These are sometimes vascular path with high morbidity. So CT remains a gold standard in terms of trying to size the valve. However, having said that, echo is still a bedrock in terms of hemodynamic data, severity of the aortic stenosis, the degree of aortic regurgitation that is present. So again, one of the most important crucial role that TE plays is the crossing of the aortic valve, the valvuloplasty when needed, and the positioning and deployment of the prosthesis. This is real time under direct visualization, followed by assessment of paravalvular leak. Core valve has the ability of being moved a little bit if you're not in the perfect position, not so much with the original sapien valve. I think the interventional cardiologists who actually do this procedure may be able to take you better through this when they talk to you tomorrow. And obviously, we look for all the complications that can occur with the procedure, the tamponade, the severity of ARs, as I mentioned. So this is a case that was of TAVR. As you can see, you assess. This is how the valve looks. Sorry, I can't go back. So here you can see the aortic valve. This is the 3D image. We are looking for severity of AS. We confirm it. And then we move on to the procedure itself. And you can see how the catheter is crossing the valve. We see the placement. There are the interventional cardiologists, along with the echocardiography, have to know which valve is being used, which system is being used, and what are the markers that we look for in placement and positioning of the prosthetic valve. Once the valve has been positioned appropriately, the valve is deployed. The core valve has a self-expanding technology and does not need to have balloon valvuloplasty, while some of the other valves do. And you again assess for paravalvular leak. As you're looking here, you can see the, some of them are not playing here. So, and the post-valve follow-up, again, beautiful results. You look for transthoracic echo, you look at the gradients, you look for paravalvular leak. One thing that you need to understand with the TAVR is that TAVR is unlike when surgeons go in and place a valve, they suture the valve to the annulus. TAVR is relying on the native aorta to support the valve. Therefore, the risk of paravalvular leak is very real because the valve can move, there can be an incomplete deployment of the valve, and that affects directly the morbidity of the patient. So again, this is, I think I'm just repeating here, so I'll skip it. So obviously, this was one of the first interventions we used to do very routinely, which was the ASD. Again, this is the left atrium, right atrium. You can see beautifully how you can directly visualize. In 3D, you can actually see the depth at which the ASD is present. And then you assess the flow. You put your septal occluder guide wire through, and if you look at this top corner here, you may actually see the occluder device, the Emplazer device that has been deployed. Actually here. You can see it here, and then it will be pulled back in a clamshell and seal it. So again, I think that the high quality real-time 2D, 3D imaging makes TE very compelling, easy to use technique. We have very high volume lab here at Methodist. We have great experience in it. And currently, combined with fluoroscopy, it remains the backbone of interventional cardiology in terms of valvular replacements. What is coming down the pipeline? Obviously, everybody's excited about 3D and even 4D printing because, you know, as I mentioned, like for example, left atrial appendage, not all appendages are equal. If you can actually make a 3D model of the appendage, you will perhaps be able to size the occluder device, maybe even customize the occluder device. So as also in the valves. So these are the exciting frontiers. I want to give a shout out to all the biomedical engineers who work on this because I really feel as a clinician at the other end, we get all this amazing technology to use, but it wouldn't be without the amazing scientists who have actually made it happen. So thank you all very much, and thank you, Dr. Lumsden.